It is. Thank you very much. You can.
Okay. Okay. أولا طبعا I'd like to thank you all برضه for holding on وتستحملوا إن إحنا نستنى لغاية الوقت المتأخر ده. فأنا I'll try to make it as interesting and useful as possible. أنا دايما whenever I talk about these experiences, these very long years, now it's been more than 2 decades where I've been working on acetabular fracture. وفي وجود أستاذي الدكتور حازم بيه عبد العظيم, I cannot start before acknowledging the value of tutoring me over many years until I could actually become an acetabular surgeon. My junior colleagues, younger ones, now very experienced as well, كلهم بيتكلموا كتير قوي على new techniques وال percutaneous fixation and so on. I'm not one of those very enthusiastic about percutaneous fixations. I like to go back to the basics. And I'd like to remind you of a fracture such as this one. The fracture that most people in the past, not in the very far past, we used to call it a fracture dislocation of the hip. Well, fracture dislocation of the hip اللي هي mainly the posterior wall fracture. This is what we see. في crack هنا. Like many people will tell you that perhaps this is nothing more than a posterior wall fracture. So I will start by telling you, is it such a simple fracture? It might look simple, but I don't think it is that simple. In fact, the literature have started to tell you, and I think this has been mentioned by some of my colleagues earlier on, that the fracture that we can most unpredict the results for is the posterior wall component of any fracture, whether a pure posterior wall associated with a posterior column, the subject of this talk, or زي ما اتكلمنا قبل كده ساعات الترانسفيرس والتي و any other fracture can be associated with the posterior wall fracture. So this is the type of fracture where you can think that you've done a good job and then you end up with not such a good result after all. So what is the accurate diagnosis of this injury? لو بصينا على ال AP view, and if we really can zoom in to look at the details, we can see first of all that this head is dislocated. This is why initially people used to call it the fracture dislocation of the hip. The Shenton's line here is indeed interrupted. There is this thing we call the French cap sign, القولونسوة الفرنسية, اللي هي on top of the femoral head. It looks like a cap. It denotes the presence of a posterior wall, and then there is this fracture. But if you look carefully at the ilioischial line here, there is a double ilioischial line, and this is different from the intact side. And a double ilioischial line means that there is a fracture plane within the plane of the screen, within this two-dimensional picture. وبالتالي لو حبينا نوصل ل-accurate diagnosis, I can definitely يعني swear and tell you that this is an associated posterior wall, posterior column. But let's have a look at another modality that now shows us very easily what the fracture is about. This is indeed a posterior and superior wall in the same time. It's a large posterior superior wall. There's a break which is going in this area, and it's going probably beyond the posterior area and involving the posterior column. So we have a posterior column, and we have a superior and a posterior wall, very comminuted. And if we look further on and we want to study it, there are so many variables. It's a fracture dislocation of the hip, but not such an injury, simple injury after all. لو بصينا كويس هنا, we will look at this subchondral fragment of bone. This is marginal impaction. This is still marginal impaction. There is comminution between the wall and the column. And in the coronal reconstruction of the CT scan, you can see the very large dome marginal impaction here. This is a dome marginal impaction which is comminuted. There's a lot of confounding variables. We call them negative confounding variables that can jeopardize the results of your reconstruction. So the classic fractures, without going into the fancy details of percutaneous fixations, the classic fractures demand looking at details, and the details are what we're trying to teach you, and these are the learning outcomes you need. The planning of the surgery is something you need to consider. Where and when you're going to be putting your patient on the table, what type of approach, the bag of tricks concerning the issues of reduction. Remember, these fractures are not as simple as you think because they're not tolerant to malreduction. They need an anatomical reduction and a rigid internal fixation. So this complex of a posterior wall with a posterior column is even more and more demanding. There are lots of details about it. And remember that the posterior wall in particular has this entity of negative variables. In addition to the osteoarthritis we are trying to avoid by an anatomical reduction, there are some factors that can occur even without us being able to influence it. The AVN and the chondrolysis that tends to happen with very severe injuries, and especially if you did not reduce your femoral head in a timely fashion. Lots of details. You have to reduce all the components. Multiple K wires can be placed in order to free yourself from using bulky reduction clamps. Then I always like to fix the posterior column first, even with a sort of permanent but not full fixation. And then I end up with this plate, and that's the classic plate we have all learned. And basically it will hold both the column and the wall. So this one is for the columns, this one is for the wall and the columns, and then you can remove your K wires and finish your fixation. And this is what you see. This is the iliopectineal, this is the iliac oblique view, whereby you can see the curving of the plate along the joint space. So it's simple, but not so simple. What did we do in this fracture? By simply looking at this view, we reduced the posterior column anatomically, we elevated and we grafted the marginal impaction. You can see here the sites of harvesting of the trochanteric graft. So we've actually elevated and reduced the marginal impaction. We put a posterior wall to increase the fixation, reduce and fix the posterior wall as well. So this is what it looks. This is the obturator oblique. Now you can see that the posterior column has been well reduced, and this is what it looks like in the iliac oblique view. So when do I start my surgery? I start my surgery from the moment I see the films and from the moment I start doing my planning. And I tend to tell all my junior colleagues, the trainees, that I do my surgery 3 times. I start doing my surgery during the planning. Then I do the surgery from the moment I put the knife to the skin. And I do the surgery again mentally when I see the post-operative x-rays to see whether I've actually accomplished all the points of my pre-operative planning. When I assess my injury, I have to look at the sciatic nerve because it's a common site of injury, and I have to consider what are my expectations. The patient and the family have to be properly counseled because you need to let them know what to expect. How long will the patient stay non-weight bearing, especially if you have a marginal impaction? And then you have to tell them what are the risks, what are the possible complications. They do not have to be surprised about needing to do another surgery if things don't go very well. And you need to communicate with your anesthetist because you need to tell them how long it's going to be, what is the position you will put the patient in, whether a regional anesthesia is accepted or not. The position, we all use the Cocker-Langenbeck approach for these posterior fractures. I tend to prefer to use the prone position for anything that is more than a simple posterior wall. There are pros and cons for the prone position. The pro for the prone position is that it gives you a much better access to the greater sciatic notch. In fact, it gives you a very good access to what you feel. So when you can put your finger through the greater sciatic notch, and when you can feel the posterior column, whether it's nicely reduced or not, we don't have this fancy table, the Judet-Tasseri table, but we can all have simple tables. It has to be a radiolucent table for good fluoroscopic examination. You need something that can allow you to bend the knee to relax the sciatic nerve. In this position, it's easier if you need to put an SI screw to do it, and you can easily put an anterior column screw in the prone position. What is against it? Many surgeons are not very familiar with this position. You cannot extend the fracture anteriorly as in the lateral position. In the lateral position, you can do a greater trochanteric osteotomy if you want. You can do a flip dislocation. You can combine the posterior with an anterior approach in the floppy lateral position. But in the lateral position, the main handicap is that the femoral head being pulled by the gravity will tend to displace your fracture, especially if you've got a more extensive fracture like a posterior column, a transverse, a T, or an associated both column fracture. So for this, you need to do some tricks like putting multiple stacks of drapes, pushing on the knee downwards, elevating the proximal part of the thigh, and this can give you some retraction to have a good look inside the joint when you do the Cocker-Langenbeck in the lateral position. This is a very, very important issue. Many people talk about orthopedic surgeons as if they are carpenters. And in fact, إحنا مش نجارين, we are surgeons. And we have to be particularly interested in the biology for the union. And it's not only about the avascular necrosis of the femoral head, but the avascular necrosis of the columns as well as the walls which have been fractured is as important as the avascular necrosis of the femoral head. If you do not respect the soft tissues, you're in trouble. I love to keep the posterior wall in particular with the soft tissue. And when I retract the posterior wall, as in here, it has to be retracted like the cover of a book. It has to be opened like a book with preservation of the soft tissue. I always like to use these self-retainer retractors, especially with blunt-edged retractors. I put them within the inside of the wall and I retract the wall up. And then you can see here the femoral head. This is the bed of the fracture, and the blood supply should be abundant because the soft tissue was minimal. And the only elevation of soft tissue I do is at the edge of the fracture, 2 millimeters of the fracture edge with a sharp knife. The periosteal elevator has no role in this surgery. Then after you reduce and fix, this is the view you have to see. So this is superior, this is posterior, this is anterior, this is the vastus lateralis, so this is superior and this is inferior. And the wall, all the way continuous with the capsule covering the femoral head, has to be in one syncytium, one continuous flap. If you don't have this, you've jeopardized the blood supply. We've talked about reduction tools and techniques. These are the tools. I'm not going to talk about them. Dr. Ahmed Azzam talked about them extensively, but few tricks about what to do with the wall fragment. This is a very important little tool, the ball pointed pusher. And I usually use 2 of them at least in my set because I need to rotate the fragment. So one ball pusher goes inferiorly, one goes superiorly, and I rotate and intermingle the 2 together until I actually squeeze and push back the wall in place. And my finger is more accurate than my eyeballs. And then obviously I need to keep the flap of the soft tissue attachment. You need to see, you need to feel, and you need to confirm with an X-ray. So you see the reduction, you feel that it is really anatomically reduced, and then you take a picture to make sure that everything is in good position. Temporary K-wires for fixation. And then you have to learn what type of implants you will use. With the wall fracture, interfragmentary screws are very useful, as well as the columns. The columns require a little bit of tricky positioning and orientation, but the wall, you have to fix it with an interfragmentary screw. Nowadays, I rarely ever use a 4.5 millimeter reconstruction plate. For every 100 acetabular surgeries I do, I rarely use 1 or 2 4.5 millimeter plates. Most of them are 3.5 millimeter reconstructions. The plate, which is 3.5, is quite rigid and it's quite elastic in the same time. You need to bend the plate in 4 bends in 3 directions. So this is one bend, which is very classical for the ischial tuberosity. There is another bend which goes along this plane. I will show it in another view, along the curvature of the wall. There is a bend along the direction of the edge of the plate. This is the 3rd bend. And then there is a twist along the long axis of the plate because the flat surface of the ischial tuberosity is not in exactly the same orientation as the flat surface of the supraacetabular area. So you need to twist the plate in 4 directions. The plate can be under-contoured if you need to compress heavily a posterior wall, and it can be over-contoured if you need to close a far cortex, and in this case, if you need to close a transverse component or a T component by a posterior fixation. Where do you put my screws? This diagram is not very accurate. My first screw is usually in the hole above, so I don't start with the most distal screw, but I start with the proximal screw of the 2 distal ones. And then you push on the plate in posterior wall, this sorts of buttresses, the wall fragment. And I always like to put the plate very close to the wall, very close to the wall edge, but very away from the labrum. It should never be on the labrum. If your plate is on the labrum, you're in trouble. So I always use a knife and I feel the bone towards the joint on the inner side of the plate. This is where it is. The posterior wall is probably going somewhere around here because this is the anterior wall, as you see. This is the posterior wall, and the posterior wall has to be somewhere around here. And I put the knife in this area to make sure that there is bone and there is no labrum close to the plate. Intraoperative fluoroscopy, we talked about this in last webinar, but it's so important. I have to double check and tell you, beware of screws in the joints. Remember this motto. If you can bring any screw that you're doubting outside the joint in any single view, it's outside. So if I'm doubting about this screw, which is the third one from above, this screw is doubtful. Let's have a look here. So this is the screw that I'm concerned about that might be inside the joint. So when I take this view, which is a both hips lateral view, you can see that this is the second screw from above. It's outside the joint. So although in this view it looks inside the joint, in this view it looks out. If it's out in any view, it's outside the joint. If it's inside the joint, it's in all views. You can tilt the fluoroscopy as much as you like until you really obtain tangential view to the joint to make sure that you've reduced the fracture well, and again the screw is outside the joint. The CT scan is your last confirmation about the position of your screws. Another confounding variable, very important, people talk about is the marginal impaction. What is marginal impaction? In fact, it is very similar to the split depression fracture of tibial plateaus. And in fact, it's the subchondral bone of the acetabulum which has rotated. This is the marginal impaction. You can see it here. You can see it in this fragment there. So instead of having the cartilage looking facing the femoral head, it is looking away from the femoral head, because as the femoral head was dislocating, it's impacted the margin and produced what we call a marginal impaction. It compressed the cancellous bone on the undersurface of the subchondral bone. How do you handle it, and what do you expect? Is it a negative confounding variable? It is, but we have a debate about its true influence on the long-term results of this injury. This is marginal impaction. You can easily see it here. I picked up this case in particular because in this case, I wanted to show you the difference between a posterior wall, which is in place, with a marginal impaction inside. Again, this is the typical marginal impaction, and this is the wall fragments. Intraoperative in the picture, this is the femoral head, and this is here the cartilage of the marginal impaction. And this forceps is introduced in the space between the femoral head and the marginal impaction. When you want to elevate it, you have to use either an osteotome or a Cobb elevator, whatever that you put on the back side of the marginal area. You dissociate the compressed cancellous bone behind this marginal impaction, you push it, and you template it on the femoral head. Then it looks like this. It's right there on the femoral head. This is just some hematoma, and this is basically the graft after it has been placed. And then the wall will have to go on top of all this area. So this is a young officer, he's actually in the police force, who had this injury while he was a cadet in his university in the military academy. And when he fell and he had this injury, he was told by many people to leave alone. You might wonder whether or not there is in fact a posterior wall. Well, I mean, it looks like a very benign kind of an injury. But when you look at this injury and you ask yourself whether there is a posterior wall fracture, I like to follow sequentially the CT cuts, the axial ones of the acetabulum. As you go from above below, you start to see that there is an impacted fragment here and there's a gap. And then as you go further on, the gap is even more and more. So on the plain view of an X-ray, you probably will not evaluate and assess properly this marginally impacted areas. So what do? We had to elevate and go like an osteotomy and elevate the posterior wall, expose now the marginally impacted fragment, elevate it, put a lot of graft behind the marginally impacted fracture, and then when you do that, you can fix them back. So this is what it looks when we've elevated the fracture with the graft in place, and you can easily appreciate the fact that this has been anatomically reduced, and this probably should give them a good functional results. That's what it looks like, and this is the post-operative. Now, wall comminution is one of those fractures that can actually have a negative confounding variable. In fact, this is one of the very recent fractures. I've just done this 3 days ago, and there are lots of details we have to look at in a comminuted fracture such as this. This is in fact probably a transverse fracture in place, just a crack transversely, which I ignored completely. And all these are the comminuted injuries. There is an injury there, there is another one over here, and there is another wall which is inserted in this area there. And the head is obviously dislocated. Why I'm bringing this to show you how a simple fracture dislocation, a posterior wall fracture, only because it's comminuted, required all this amount of hardware. So this is one plate that was actually fixing an extra-articular component, which was here. This is the typical buttress plate that was mentioned earlier as a technique of reduction. The screws are outside the fracture, and then this area there will push one of the walls back, and then another plate will contour and will reduce the fracture properly. Another fracture here that might look to you like a simple injury. The only thing you can see in this AP view is that perhaps the posterior wall line is sort of interrupted. It walks like this. This is the intact posterior wall for comparison. And when you start with the posterior wall here, there is a dip there. There is some overlapped fragments, and then there is an emptiness here. And perhaps you might think that this head is in place. It's not dislocated. But when you obtain different views, you can start to appreciate there are more than one fragment which are fractured. The iliac oblique will add to you that this is not just a posterior wall, but a posterior wall with a posterior column. So it's an associated posterior wall, posterior column. The CT scan will show you the marginal impaction here. This is the cut number 6 at the level of the anterior inferior iliac spine here and there. And these are the most important for me to appreciate where the dome is injured. This is the fracture of the posterior column. These are the marginally impacted fragments. And that's after we've done the reduction and fixation. So this is the plate that reduces everything. These are 2 spring plates. I always use these with comminuted fracture. It's a 1/3 tubular plate that I cut in the middle. I bend the edges of the wall. It becomes like a spike. I put them back in place, and this is how I obtain it. In fact, this is one chap I've done many, many years ago, more than 15 years ago, probably in England. And some nice colleague of mine sent me later on at the 9-year follow-up these films. So these films I've received more than 5 or 6 years ago, and as far as I know, this guy has done virtually well. He's one of those taekwondo experts, and this is the post-operative CT scan. So is marginal impaction a negative confounding factor? We can discuss about it academically. Some people put it, Kregel put it in his paper as one of the negative confounding variables. I have published a series of more than 84 cases where I found that the marginal impaction, when it's properly done and anatomically reduced, it doesn't produce negative results. And in fact, Joel Matta has published on the same, and I think he holds the same opinion. If you elevate the marginally impacted fragment well and you fix them well, they tend to give you results very comparable to the simple posterior wall fractures. What about the posterior column? There are lots of tricks we use to reduce the posterior column. We mentioned them last time. Very quickly, the corkscrew is an important one in the chance to derotate the posterior column. The pointed reduction clamps are important. The use of 2 screws with a large pelvic reduction clamp is also something else that we can use. Strategic positions of the pointed reduction forceps. This one is also extremely important. And you can put them either in the greater sciatic notch or in the lesser sciatic notch, depending on what is the direction you want to pull the posterior column to. This particular chap that you see, this is not a bad quality X-ray. This is an X-ray taken from a pelvis in a 170 kilograms individual. And in fact, he was so overweight, he could not go in the CT scanner. The head was posteriorly dislocated through the greater sciatic notch. The anterior column was intact. You can see that the anterior column was intact. The posterior column was fractured with a posterior wall. So this is a guy that I could not actually place in the prone position because of his very large belly. And in fact, I couldn't actually try to ask anybody to retract his buttock with 170 kilograms. So this is what it looked like. And this is what we obtained when you put the patient in the lateral position. And this is one of the very few patients I needed to use a 4.5 millimeter reconstruction plate because he was really very, very heavy. So this is what he looked like. This is the iliac oblique view. You can see the anatomical reduction. And this is the obturator oblique view. And that's the result we obtained. Lastly, a trick, because people like to use percutaneous technique. This is not a percutaneous technique. This is a percutaneous insertion of a screw with an open technique. I don't like percutaneous techniques. I'm sorry for all the youngsters who are very enthusiastic about percutaneous techniques. So this is basically a very low posterior column. In a Paget's disease, if you left it, it's going to give you a painful non-union. You need to reduce it and fix it. So in a classic approach, we put the patient in the lateral decubitus position. I reduced openly the fracture, as I'm always used to. And then basically, we inserted the retrograde posterior column screw for a very low posterior column. So you can see this is a standard Cocker-Langenbeck, and this is the guide pin going very close to his back passages. And this is a very, very tricky area. And you need to make sure that the sciatic nerve is away from that. If you're doing this percutaneous, you need to flex and abduct, ABD, the hip. But if you do that in this standard classic technique, you can put your finger, protect over here the sciatic nerve, and then whack up the screw. So beware of this position, because you can actually easily injure the sciatic nerve in that retrograde screw. The very long screw going along the subchondral bone of the joint got a little bit bent, but that's something that we're used to in long screws in acetabular surgery. And that's what it looked like. And you might think that this is intra-articular, but in the iliac oblique view, the screw is classically totally outside the joints. So the take-home message here is that posterior fractures are not as simple as we think. They need careful planning and preparation. There are too many details you need to assess for adequate reconstruction. Reduction can be tricky. Beware of the biology, and practice, practice, practice. دلوقتي أنا هسأل حضرتك يا دكتور خالد, do you think I've been hearing